All right, we can go ahead and kick off our provider forum for today. As folks are aware, this meeting is being recorded and it will be posted to the DSS website. I will turn it over to Dr. Fatmata Williams for some quick opening remarks before we get into the meeting content.
Thank you very much, Tiffany. Good afternoon, everyone. And for those of you who do not know me, Tiffany just introduced me as Dr. Fatmata Williams. I am also the Deputy Medicaid Director of the state of Connecticut, and I am a co-designer with all of you of this maternity bundle that has been implemented almost a year and a half now. So I want to welcome you to today's maternity bundle provider forum. And I want to thank you for taking your time to join us and for the work that you do day in and day out to support moms and babies and families across Connecticut. This forum is really an important place for us to highlight some of the changes that have occurred over time, our successes, and any updates that we hope to implement in the bundle with all of you. We deeply value your collaboration, your expertise, and your ongoing commitment to innovation as person-centered care for our members here in Connecticut. We hope that your contributions today will help us to evolve this bundle in a way that's meaningful and impactful. So thank you again for joining us, and I'll hand you over to Tiffany. Tiffany, you have the mic. Thank you.
Thank you. Geisha, we can move on to the next slide, please. All right. Welcome, everyone. Before we get into the meeting, we'll also start with some ground rules. First and foremost, this meeting is being recorded on the DSS YouTube channel for later viewing. I'll also note that meeting materials will be posted on the DSS website, so you will have access to everything that we discuss at this meeting. Um, I'll also add we value your time, so we're going to try to cover all of this information within the hour that we have. But we also welcome any additional questions or feedback following this meeting if there's things that we don't get to during this time. In terms of some other Zoom logistics, we ask for you to please mute yourself if you're not speaking. You're also welcome to enter the chat and identify yourself by adding your name and your organization before we begin. Otherwise, we ask that you limit use of the chat unless you're having any technical issues. There is a Q&A button available for posting questions anonymously. If you don't see that right away, that can be found by clicking on the More button. It's a circle with three little dots in it, and that might show some other features that are available, including the Q&A feature. And again, like Fatmata said, DSS really values our collaboration with the provider community. So if you also have questions, you're welcome to just raise your hand. We want to make this a collaborative meeting, and so feel free to just chat with us and raise questions as they come up. Next slide, please. In terms of our agenda today, we're going to kick off with some quick introductions of the presenting team. We'll do a reminder and reground ourselves in the program goals, as well as a reminder of the overview of the current reimbursement structure. And then we'll dive into the meat of our meeting's content, which will be discussing the proposed changes to the incentive payment calculation methodology, as well as to the prenatal visit measure. And then we'll finally close out with some next steps and a discussion with any Q&A questions that come up. Next slide, please. So in terms of some quick introductions, wanted to just introduce the folks who are on this call who will be presenting today. From our actuarial team, we have Mercer joining us. And so we have Caroline Scott. Let me pull up everyone's name so I don't miss anyone. We have Sean Thiel Sachs, Charles Lassiter, Eileen. Here's Eileen. We have Eileen with us, and we also have Geisha Gomez. Hopefully, I didn't miss anyone from the Mercer side. They're our actuarial partners for this program. We're also joined by the CHN team. They're the backbone of all of the provider engagement for this program, as well as support with quality measures and reporting. And then and in the CHN team, we have Kim Osno, we have Eric Preston, and Greg Barbiaro. And then finally, for myself, my name is Tiffany Lunan. I'm joining from Faulkner Consulting Group. We've been supporting DSS with program development and overall project management on this project so far. So with that, we can proceed to our next slide. So we'll be discussing some brief program goals. Next slide, please. Um, So wanted to just reground ourselves in DSS's commitment in one of the kind of key forces for this program. The big goal that's driving the big driving force behind the maternity bundle program is really health equity. So this program really started back in 2020 with the goal of having a very strong commitment to remedying historical disparities in maternity care. And as such, a lot of this health equity is at the center of DSS's work in developing this bundle. So, as part of the goal to promote health equity throughout the maternity bundle, this program really aims to address and remedy disparities in access, utilization, and outcomes for pregnant birthing people. There's a big emphasis placed on birthing people of color, people with substance use disorders, a high social vulnerability index. You can see that in some of the design decisions that we made, where there was a very deliberate goal to make sure we're including social risk adjustment, recognizing, we want to place an emphasis on these populations. And making sure that providers feel incentivized to care for them. We also made sure to center the lived experiences of Husky members in the way we designed and implemented this program. So back in the kind of early pre-design days, a lot of work was done, including focus groups with Husky Health members to really understand, where are there improvements that we can make to the maternity care experience through this program. And we also tried to include a couple members throughout the design process in the early days. We have also aimed to include access um, to additional care supports, such as doulas and breastfeeding. We know these are huge levers that can really help and make a difference in the care that Husky Health members receive during their perinatal experience. And then finally, we tried to really examine all services through a lens of race and equity to ensure that we're really working to close our health equity gaps. Next slide, please. So I will now pass it over to the Mercer team, Caroline Scott, to present on this next section.
Thank you, Tiffany. I'm Caroline Scott, the actuary with the Mercer team, currently supporting the bundle. Just wanted to give everyone an overview of the current maternity bundle program case rate structure. So the maternity bundle case rate became effective in January of 2025, and it's a bundled payment intended to take fee-for-service professional payments and move them into a single comprehensive payment rate for an episode of care. The case rate is prospectively paid based on, it's a fixed rate based on the provider's historic maternity experience, and we are beginning to blend in some risk-adjusted statewide experience effective this year. In the case rate, if the maternity bundle member is receiving cover services from an attributed provider, that attributed provider's services will be paid at the case rate. Maternity bundle members are still able to receive services from other providers. Those could be paid fee for service, or there could be a change in attribution based on the way that claims are submitted. But the purpose of the bundle really is to encourage greater care efficiency and care coordination by encouraging providers to have longer relationships with patients, improving their care coordination and quality, and reducing the cost. The bundle payment structure will provide the providers an opportunity to realize shared savings if total costs are below the target price. And we'll talk a little bit about target price in the next slides. But providers may also assume risk for costs that go above the target price. So moving to the next slide, please. So the maternity bundle case rate is intended to provide a fixed prospective payment for the maternity episode. The maternity episode is defined as the period from 280 days prior to delivery to 90 days postpartum. And the maternity bundle episode begins when a qualified E&M trigger code for second trimester or greater is submitted. So the purpose of the episode is really the episode is defined in terms of those periods. There is a 30-day reporting period for newborn care as well. And then the episode costs are subject to a retrospective reconciliation after the performance year. So all services that are included in the maternity bundle will be reconciled against the target price. The target price is based on the provider's experience from the year prior, with a blend for statewide experience and any updates to acuity reflected. Next slide, please. So looking at the bundled services, we can see that the services included within the bundle are in the professional group. We have pregnancy services, so the standard monthly prenatal visit, in-house imaging and midwife services are covered. Those services are fee-for-service if not done in-house. The same is true for lab and diagnostic. For providers who have opted in, the prenatal doula visit is covered as part of the case rate. For providers not adding or opting in, it can be fee-for-service. Care coordination's covered, group education, child education, preventive screenings. The professional portion of the labor and delivery service is included as part of the bundle, including doula services during birth, if that is opted in. And then postpartum services up to 90 days are included as well. The lactation support is provided to all providers. All providers receive a $7 PMPM add-on to fund lactation support, and postnatal doula visits are also available subject to the statewide limit on doula services. Next slide, please. So the maternity bundle program is really intended to represent a hybrid payment structure. So there is a prospective payment. As we mentioned, that payment is based on historic provider experience. And it's paired with a retrospective settlement where actual experience is compared to what was paid under the case rate. Historically, especially for CY 2025, case rates are calculated using historic costs for these services. So all services within the bundle that were performed during state fiscal year 2022-2023 were repriced to the current fee schedule to create the CY 2025 rates. Any service that is billed to an attributed provider during that period was used to create the initial case rate for CY 2025. We did make some adjustments for CY 2026 to update for the new fee schedule, as well as to blend in acuity and statewide maternity experience. We are doing a reconciliation at the end of each year. It has 6 full months of runout, and it's going to be taking place in the fall by the end of September. And that is where accountable providers that have generated shared savings, essentially the fee-for-service value of the encounters during the performance year, fall below the target price, can realize can receive an incentive payment subject to quality. Effective performance year 3, which would be calendar year 2027, the state is considering introducing shared loss for maternity care episodes that exceed the target price. And for both the shared savings and shared loss distributions, there will be a relationship to quality. So those providers that are on the higher end of quality can realize a greater portion of shared savings and have a reduced liability for shared losses. Providers towards the lower end of the quality spectrum would have a reduced eligibility for incentive payments and increased liability for shared loss. Moving on to the next slide, please. As I mentioned, we did make some updates for calendar year 2026 case rates with the goal of moving the case rate structure towards ultimate alignment with the target price. The target price that's used during reconciliation is a 50-50 blend of the provider's prior year experience and the statewide acuity adjusted average. As I mentioned earlier, initial case rates were purely based on a provider's historic experience. So in order to bring those closer together, we are moving case rates towards a 50-50 structure over 3 years. We are planning to introduce a sixth of the rate being risk adjusted this year, calendar year 2026, as we discussed during the November forum. Next year, the plan is to have a third of the total case rate be subject to risk adjustment. So 2/3 of it would be the provider's historic experience, and 1/3 would be the acuity adjusted statewide average. And then for calendar year 2028 and beyond, it would be a 50-50 mix, nearing the target price. The purpose of this adjustment is to reduce the likelihood of variance, significant variance at reconciliation, particularly as it pertains to liability for shared losses. So by moving those two metrics closer together, we're hoping that the target price and the case rate will be much more closely aligned. I will pause. Are there any questions so far about the reimbursement structure before we move on? Moving on to the next slide, please. So as Tiffany mentioned, there are some proposed changes to the shared savings incentive payments proposed for CY 2027. I do want to be clear that these are proposed changes. DSS is still in the process of determining potential changes, and certainly we welcome your feedback, as Dr. Williams mentioned. But currently, the accountable providers are eligible to receive incentive payments of up to 50% of the total shared savings. So if we look at the total savings generated, that would be the difference between the target price and the fee-for-service value of the encounters during the performance year. 50% of that is retained by the state, and then up to 50% of that can be distributed to the provider based on quality tier. For those providers that are in performance tier S, which is the 80th percentile or higher for performance, they will be scored on performance only. So providers who are in the top 20% of providers in terms of absolute performance will not be required to demonstrate improvement in terms of scoring as it's applied to shared savings and loss. For all other providers, it's based on the better of, just to be clear. So for those that generate a savings or a loss, it would be what the better of percentage, the performance tier or the improvement tier. And we will be going through some examples to demonstrate how that's applied. So for the provider, if we have a provider who generates a savings, and the provider is in performance tier A and improvement tier C, the savings distribution is going to be based on the performance tier A. For the loss, it would be based on the lower percentage. So whatever percentage is generated by performance tier A versus whatever percentage is generated by improvement tier C, we would pick the lower for loss liability. Similar to the risk adjustment phase-in, loss accountability is going to be phased in over 3 years. So we are not going to be phasing in anything on the shared savings side. That would stay consistent. But in CY 2027, up to 1/6 of the total loss would be subject to, or 1/6 of the total loss could be accountable to the provider, a third in PY4 and half in PY5. So ultimately mirroring the shared savings approach on the loss side for 2029 and beyond. Next slide, please. So as we look at performance tiers, the left side of the chart shows the existing shared savings tiers as provided in the state plan amendment. So this is what's going to be used for the CY 2025 reconciliation. You can see that there are two different ways in which performers are going to be scored. One is on objective performance relative to the maternity bundle population. We do determine percentile based on delivery count, so there is recognition of the fact that not all providers are of equivalent size. This is a weighted percentile distribution. But for providers that are below the 55th percentile, that is performance tier F, and the projected distribution would be 50% of the 50%. So that would be essentially 25% of total shared savings would be eligible. And then the percentages increase up to performance tier S, where it's 100% of that half. So if in terms of total savings, we can simply multiply by 50%. As you can see, the performance losses phase in over 3 years. And the final column, the performance percentage losses for CY 2029 and beyond, are intended to mirror the savings side. So if you look at the loss liability for performance tier F, that's 100% of that half. That mirrors the performance percentage earnings for shared savings for performance tier S. Similarly, performance tier A, 90%, if it's a savings, is going to mirror loss tier for D at 90%. And there's a similar mirroring applied on the improvement tier. So it's based on improvement on your total performance for the metric score. So if a provider does not show improvement year over year, that would be improvement tier F. 0 to 3% is improvement tier D, and on from there. Next slide, please. So in this example, we have a provider that is in performance tier S. So they are above the 80th percentile of the peer group. So because this provider is in performance tier S, only performance tier S is considered. We are not looking at improvement in terms of shared savings and loss liability. So as we look at this, we can see that this particular provider had a performance score in the 91%, and that was in the 94th percentile of the peer group, placing them in tier S. Their pay per performance average improved 1%. So technically they would be in improvement tier D. However, because they are in that S tier for overall performance, they are not required to demonstrate improvement to receive shared savings. So 50% of the total is going to be adjusted using the percentages for performance tier S, and the same thing would be applied for their loss distribution. Okay, moving on to the next slide, please. The next slide has an example of a provider who has a performance score 63% that puts them in the 72nd percentile, and their improvement score is 10.5%. So in this example, the performance tier score is lower than the improvement tier score because they're in tier A for improvement, but tier B for performance. So in this case, the shared savings and losses are both calculated using improvement tier A. Improvement tier A would pay out a higher percentage of shared savings and would have a lower percentage for shared losses. Moving on to the next slide, please. So shared savings and shared losses, DSS is sensitive to the fact that shared losses have the potential to create cash flow concerns for providers. So there is going to be a revenue cap introduced for both shared savings and shared losses. And the revenue cap will be based on the total maternity revenue. So that would be the fee-for-service payment and the case rate payment. So total maternity revenue provided during a performance year Based on the quality performance, as you can see, there is a symmetric approach applied. So for savings, shared savings are capped at 5% for those that are in performance and improvement tiers F. For those in the basic upper quadrant, so tiers S through D in improvement or performance, and tiers A through F in improvement, it's 10%, and then you can see 7.5% for the others. There's a mirrored approach on the loss side. So the cap percentage, the revenue cap, is not going to be phased in. That's going to be applied evenly through all years. And any shared savings or shared losses that exceed the revenue cap, and we will walk through some examples, but you can see this. All of those will be truncated to the cap percentage. So if, for example, a provider has a shared loss that is 12% of their maternity revenue, that would be capped at no more than 10%, depending on quality. So if that provider was in improvement tier A and performance tier S, it would be 5% of their revenue would be their loss liability, up to 10%. Next slide, please. So we have an example here of a provider, and this is kind of intended to walk you through how the shared savings and loss liabilities would be calculated. So in this example, the provider is in performance tier A and improvement tier C. So because they are not in performance tier S, both of those tiers are considered. We would be basing both of the decisions on the better of, so the better score would be A. If we look at their revenue, because they are in performance tier A and they have generated a savings, if you look, you can see that the crosswalk of performance tier A and improvement tier C is a 10% cap. So in this example, the maternity provider's total annual revenue was $10,250,000. So the cap is going to be 10% of that, or $1,025,000. The savings is the difference between the target price and the fee-for-service value of the encounters. So this provider has generated a total savings of $250,000. So the state holds $125,000 of that, and then the other $125,000 is shared with the provider. So the maximum distributable shared savings would be $125,000. So if we look at the scenarios in the bottom table, you can see under the upside only model, which is what DSS has utilized for CY 2025 and CY 2026, there is no liability for shared loss. Because the provider is in tier A, they're eligible for 90% of the shared savings distribution. So that savings would be 90% of 125,000. So it's 90% of half, or 112,500. When we look at that, we take the 112,500, which was the loss before the revenue cap, and we compare that to the annual maternity revenue. So that 112,500 is divided by the 10,250,000, and we could see that that savings would be 1.1% of the revenue. So because that savings is under the revenue cap of 10%, there is no change to the savings distribution, and the savings is paid out at 112,500 in all years. Because this provider is generating a savings, there is no phase in. So you can see if you look at PY3, PY4, and PY5, the math is the same in all years in this example, because there is no loss liability and no phase in applied. And in all years, it's under the cap imposed by or under the limits imposed by the revenue cap. I will pause. Are there any questions on example number 1 before we move to the next example? Just clarifying, for those providers that generate savings, there are no changes between years. The savings percentages are proposed to stay the same in all years. Next slide, please. In example 2, we have a provider with similar performance and improvement tier scoring, A in performance tier, C in improvement. Based on that, the revenue in the previous example, the savings was paid out at 10%, but because this provider has generated a loss, the loss is capped at 5%. So they fall in the top performing quadrant and they have reduced loss liability as a result. In this example, the provider's annual revenue is $11,750,000, and they generated a total loss of $2,750,000 during the year. So again, DSS takes half the loss and the other half is shared with the providers. So in the upside only model, as you can see, there is no liability for the shared loss. DSS would have absorbed the full $2,750,000 loss. But beginning in PY3, there is going to be a proposed phase-in. So in this example, as we mentioned, the phase-in happens over 3 years. So in the first year, they're only liable for 20% of the shared loss. In PY4, they're liable for 40% of the shared loss, and in PY5, 60%. And that would be 10% of the total loss, 20% of the total loss in the second year, and 30% all final years. So when we take a look at that loss, you take the shared savings, which is the the shared loss, 1,375,000, multiply that by 20%, and that's how we get the $275,000 loss in PY3, $550,000 loss in PY4, and $825,000 loss in PY5. However, the loss in PY5 exceeds the revenue cap. So as you can see in PY3 and PY4, the loss falls below 5% of total revenue. And so there are no adjustments made to the loss. But in PY5, because that $825,000 loss would exceed 5% of the annual revenue, the loss liability is capped at $587,500. We'll pause. Are there any questions? So the revenue cap is intended to provide stability to providers by really making sure that those losses are capped, and ensure that the providers do not exceed 10% of total revenue either way in either shared savings or loss.
This is Mark. Can you explain again when the negative 5% revenue cap comes into play in this calculation?
Yes. So it comes into play in CY 2029 because the 825,000 exceeds the 5%. So essentially we calculate the loss and what percentage of revenue it is. So the $275,000 loss in CY 2027 is only 2.3% of that 11,750,000. So because it's within the 5% barrier, within 5%, there's no adjustment and the loss flows through unadjusted. But as you can see, that 825,000 exceeds the 5%. So then the loss is calculated at 5% of 11,750,000. And for simplicity, all revenues are the same, assumed to be the same in all years, just so that we can focus on the math. But because of the cap getting hit in the third year, you can see that it does get truncated.
Thank you.
Yeah. Are there any other questions? And just to clarify, as part of supporting providers, DSS is planning to include some illustrative modeling with the upside-only reconciliation for CY 2025, essentially doing a provider-specific simulation similar to what you see in examples 1 and 2. So we're hoping to provide essentially an illustrative model showing providers how those payments would have been made under each of these scenarios, the upside only, and then the phase-ins for CY 2027, 2028, and 2029. That way providers have the information specific to their own practice in their hands long before any financial liability would be introduced. Next slide, please. I will pass to Sean Sachs from Mercer to talk about proposed changes to prenatal visits.
Okay, I just want to double check before we dive in with Tiffany and others that there are no other questions that have come through the Q&A either before I proceed on the last section.
Nothing in the Q&A so far.
Okay. All right, so if we can go ahead to the next slide. So for the prenatal visit measures, there is going to be an update to the specifications, and we wanted to make sure we shared what that was going to look like. So on this slide, I'll just give you an overview and we'll look at it more comparatively on the next slide. So for calendar year 2026, starting effective with performance year 2, there will be a measure specification that switches the previous terminology from an or to an and we'll look at it side by side in a moment on the next slide. What I want to reiterate is that this will not have any impact on performance year 1, nor the reconciliation for performance year 1. That will all be based on existing measure specifications, and we'll be running both specifications parallel through July to ensure that we're getting the full performance year 1 with the original prenatal visit measure specifications. When we also start to look at the new specifications, there will be a new baseline set. So we won't be comparing old specs to new specs. It will be a new baseline in accordance to the new specifications. So if we can go to the next slide. So essentially, what you'll see on the screen here is on the left are the current specifications, on the right are the new specifications. So currently, the report is using or statements, meaning that the visit meets criteria for any claim where the billing slash performing provider is an OBGYN or a PCP, or any claim that has that CPT or HCPC code in one of the value sets, where the reason for the switch is that the HEDIS logic for prenatal visits has a different requirement and is a slightly more restrictive. So in that scenario with HEDIS, the billing provider must be an OBGYN or PCP, and the procedure HCPC codes needs to be in one of the value sets. So in order to be in closer alignment with the HEDIS logic, the specifications will be updated beginning in performance year 2. So you'll see on the slide that what is currently 1 or 2 is combined into the new number 1. So you have to have both 1 and 2 now, or the claim performed or billed by an OBGYN and PCP and a code. So we just wanted to make sure folks were aware of this update prior to seeing those changes in the data set, and to reassure you that this will not impact the performance year 1 reconciliation and that a new baseline for this measure will be set. The other thing I do want to mention, so the quarterly report dashboard you just received has the existing old specs. When you get your next report in July, you will have there'll be 2 sets of data. You'll see the continued data under the original specifications, and then you'll see the secondary application or new specifications for those prenatal visits with the new baseline and data as for that first quarter. Because as you know, there's a little bit of a delay in how that data can be collected to ensure some minimal run out. For my CHN partners, is there anything you would like to add?
No, this is Greg. I think you covered it. Eric, was there anything you wanted to mention?
Nope, I think you got it, Sean.
All right. And as in the past, as individual practices receive your dashboards, we're more than happy to follow up, answer any questions, go through the data together. And I know Kim and her team normally coordinates that. So that process will continue if that is needed as the specification update is applied. Any questions? All right. Tiffany, I will turn things back to you.
All right, thank you. Keisha, we can go to the next slide, please. All right, so throughout the program development and implementation, DSS has been really mindful to make a concerted effort to be to listen to and be responsive to feedback from the provider community. So this will be no different. With our updates to the PY3 reconciliation model. As Caroline mentioned, this will not be the last time we discuss this. The updates we've discussed today are proposed, and we do plan to provide illustrative modeling as part of the PY1 reconciliation reports. We'll also plan to hold another provider forum when those reports are released so that we can review the reconciliation reports and the illustrative modeling. And then we'll also provide the opportunity to really have one-on-one conversations as requested to dive deep into those reports and discuss any of the data that's shared with providers. In the meantime, we really do value your feedback. And so if you have any additional questions, comments, concerns, please submit that feedback in writing by June 3rd. Any feedback submitted verbally or after this date will not be considered. This communication can be given to Kim Osno. Her email is listed on the slide. And then we just ask in this communication, please use May 2026 provider forum feedback as your subject line, and also include your practice name and tax ID number in the body of your email.
Tiffany, there's a hand raised.
Yes, Lakeisha. In case you're speaking.
Sorry, I
Oh, no,
couldn't get
you're good.
myself off mute. I just had a question. Is this slide deck going to be shared with the group?
Yes, we post all meeting materials to the DSS website.
Okay, great. Thank you. Because I had some team members that weren't able to join and they're going to want to look at this information.
We also have a recording available too, so they can completely rewatch this if they want to go
Oh,
back
okay.
fully
Great.
as well.
Great. Thank you.
Yep. Mark?
Thank you. Can we go back to the slide about the migration of the case rate to a 50-50 arrangement?
That would be slide 12, Geisha. One more back. Okay, I think this is the slide.
So the so in the case rates, what you're migrating to is a calculation that is a mix of the statewide and the provider's historic. And there will be risk adjustment phased in. Is that right?
That's correct. There will be risk adjustment phased in. So up to half of the rate will be the statewide average adjusted for the provider's acuity. So providers that have above average acuity would have a rate or a factor above 1.0 applied to that portion of the rate. The other 50% would be based on the provider's historic experience adjusted for trend. So the initial case rates were purely provider-specific experience, and that the purpose of this is really to reduce the size of reconciliation on either side. So we want to ensure that that as much as possible, we're aligning the payment with the target price to minimize either loss liability or size of shared savings.
Is the risk adjustment clinical and social risk or just clinical risk?
It's a combination of both. So it's based on the ACG risk model. That's the largest portion of it. And then there is an upward adjustment for members that have an area deprivation index score of 9 or 10. So for the members who live in area deprivation index level 9, which would be the neediest 10%, neediest 20%. They receive an upward adjustment of 0.1 to their ACG risk score. On average, an ACG clinical risk score is a little bit over a 2. So it represents a little bit under a 5% increase for those members. For the members who live in ADI group 10, it's an upward adjustment of 0.2. And so all risk adjustment is then renormalized to reflect that adjusted inclusion of the ADI.
So a nine is an upward adjustment of 5%?
Roughly 5% based on average. So all members receive the same adjustment for ADI to their clinical risk score. On the average, a maternity bundle's clinical risk is about a 2 point, a little bit over a 2.0. So that's why I'm saying it's about 5%, but that's going to be variant based on the member's clinical risk. So for high clinical risk members, that ADI would have a less than 5% impact. And for the low clinical risk members, it would have a higher.
And when you factor in historical experience, given that providers, what is the basis for the historical billing experience if the providers have migrated to a case rate in lieu of claiming? Is it based on shadow claims?
It's based on shadow claims. So for the initial case rates for CY 2025, it was based on the 2022-2023 performance year. To provide stability, we did keep that same fee-for-service experience period when we did the CY 2026 rate adjustments. The only changes were that we updated the fee-for-service value to align with any observed changes in the fee schedule. And we also did make adjustments to account for providers that were impacted by things like mergers and acquisitions. So we did, for providers that merged with other entities, we did reflect that in the case rate.
How do you know that the shadow claiming is complete, since if it's not tied to payment, there could be less claiming than there was before? That's pretty typical, that providers are less diligent in submitting claims when they're not tied to payment, and so that could result in a distortion, basically a downward adjustment that's not valid. And my understanding is a lot of providers were billing case global rates where they didn't have to bill a lot of what they were doing on a per visit basis. So how do you adjust for those things that ultimately could work to a provider's disadvantage?
I think we're certainly going to be monitoring the the shadow billing over time. That was part of why we opted not to rebase rates and use the historic fee for service experience to set our case rate payments for CY 2026 and CY 2027. We are monitoring the value of the shadow priced encounters. CHN has developed a dashboard that we're using to keep an eye on that. And certainly we would be monitoring to see if there's variance in the value of those encounters relative to the historic fee for service.
And my understanding is that DSS has implemented effective January 1st rate increases that then are fully annualized in SFY 2027. What is, from a dollar perspective, what is the impact on the case rate payments? In other words, how much of the investment in rates is going to those services? How much more will go into case rates?
We don't yet have that projection for CY 2027 because we haven't engaged in that process. That process is going to be taking place beginning late this summer, and we plan to follow up with providers probably in the early fall to late fall with those CY 2027 projections. We are planning to adopt a similar approach where we would apply an indexed increase to the rates to basically reflect the fee for service, what would have been the fee for service value of that historic experience under the new.
So how much was the CY 2026 case rates? How much were they increased as a result of the change in payments?
It varies by provider.
Yeah, I mean, in
They were
aggregate statewide.
relatively level because there were not significant changes to the fee schedule. So in general, it was fairly budget neutral between CY 25 and CY 26.
But if the CY 26, if these were implemented January 1st and they're then consequently fully annualized for a performance year, case year, or CY 2026, I guess, Dr. Williams, is it that there were no increases in the rate investments that occurred? There were none in OB services, or they just weren't applied to the case rates?
There were increases, Dr. Schaefer, but I don't know if they've been applied yet to the case rate because we just implemented those increases very recently.
Yeah, so thank you, Dr. Williams. But the effective date is for services rendered January 1st, 2026. So it would seem to me that the case rates should be adjusted retroactive to January 1st, 2026 to ensure that they're getting the fair value of the reimbursement for services rendered after that.
I think we need to take that back. Because I think the timing, I really have to go back and verify, Dr. Schaefer. But I know we did add the OB codes were part of the rate increase. The effective day, I believe we retroed back to, January 1st of 2026. But I'm not sure when. So my anticipation was that that will show up later, after probably when we refresh for at the end of this year when we refresh for next year. That was my anticipation that
So
we would retro all of those and it was showing the
I
case rates for later.
I think that would be contrary to the intent of the statute, with all due respect. The intent of the statutory investment in rates or the state plan amendments is for services rendered CY 2026. So if you're only including it in prospective adjustments to case rates in 2027, providers are not benefiting this year for a significant investment in rates for services delivered in CY 2026.
We will take that back, Dr. Schaefer. Let's take
Thank,
that back because we may be missing something here.
thank you. Or I certainly, the we includes, I may be missing something, but it is something that seems out of sync.
Yeah,
Right.
we'll take it back and follow up with you all.
Thank you
Thank you.
for indulging all my questions.
It's okay.
Thank you. And that, just to clarify, the repricing was done in the late fall of 2025. So it was repriced to the fee schedule that was current as of that time. So any rate adjustments that were made after that point are not included in the index adjustments that were applied for 2026. But we
Yeah,
will consider your feedback and follow up.
that's exactly
Yeah.
the issue.
Yeah.
Yep.
Okay. We will take that back.
We have 3 minutes left for this meeting. Are there any additional questions that we'd like to address? If not, like we mentioned on the last slide, and we'll be sharing these slides, there is going to be an opportunity to submit additional feedback questions through email to Kim Osno. So this is definitely not your last opportunity to ask, and we certainly want to make sure that this is information that you guys understand. So please feel free to reach out by email. And again, we'll be having additional conversations around this in later provider forums. All right, if there are no further questions, we will give you guys back 2 minutes.
Yep. Thanks everyone for your time.
Thank you.
Thank
Thank
you all.
you.